So if you've ever, been caught short needing the loo right now, or maybe felt that frustration when things just aren't flowing properly, you know how much that can mess with your day.
Absolutely. It really impacts quality of life. And that's exactly what we're going deep on today. Lower urinary tract symptoms, or LUTS,
Mm.
specifically in men.
Okay, LUTS. So our sources are saying these are basically urinary symptoms that come from issues down below the bladder, the urethra, the prostate.
Exactly. And they cover both storage problems, like that urgency you mentioned, needing to go often, especially at night.
Right, Nocturia.
Nocturia, yeah. And also voiding problems, so a weak stream or finding it hard to get started, that kind of thing. Hesitancy.
And it's not just a minor annoyance, is it? It can seriously affect daily life, and it's often linked with BPH, benign prostatic hyperplasia.
Precisely. That's the non-cancerous enlargement of the prostate, very commonly.
And super common as guys get older, yeah. The materials highlight LUTS are really prevalent, especially in men over 50.
Oh, definitely. And it's a whole spectrum. You've got mild symptoms, maybe easy to ignore, then more troublesome ones needing a doctor, and sometimes, yeah, even surgery.
So our mission for this deep dive, give you a clear, high-yield overview of LUTS. Really nail down the essentials for revision. We'll cover the key bits, causes, symptoms, management.
Exactly. A concise guide. So, starting with the definition again, just to be clear.
Yeah, let's lock that down. LUTS, urinary symptoms, problems in the bladder, urethra, prostate, and split into those two camps.
Right. Storage and voiding. Storage is about holding it in urgency, frequency, nocturia. Voiding is about getting it out weak stream, hesitancy, incomplete emptying.
That storage versus voiding split seems really helpful for thinking it through.
It is. It helps frame what might be going wrong.
Okay, so what actually kicks these problems off? What are the main causes?
Well, top of the list, especially with age, is benign prostatic hyperplasia, BPH.
Right.
Then you've got, unfortunately, prostate cancer. Also, urinary tract infections, UTIs. And then issues with the bladder itself. It might not be working right, bladder dysfunction, or it could be overactive, causing that urgency.
So that overactivity, yeah.
Then there's bladder outlet obstruction. That could be a narrowing in the urethra, a stricture, or a tightening where the bladder joins the urethra. That's a bladder neck contracture. And lastly, don't forget neurological causes, things like MS or spinal cord injuries can affect bladder control.
Wow, okay. That is quite a list. Any quick ways to remember those for revision?
Let's see. Maybe think. B's for BPH and bladder issues.
Okay.
P for prostate cancer. U for UTIs and urethral strictures. And N for neurogenic.
Yeah,
EPUN.
they're clunky, but memorable. I like it. So those are the causes. What makes someone more likely to get LUTS, particularly BPH? What are the risk factors?
Okay, risk factors. Number one is definitely getting older, advancing age.
Always the way.
Isn't it just? Also, family history is important. If your father or brother had BPH or prostate cancer, obesity is another one.
Really, obesity.
Yes. And interestingly, certain medications. The sources mention both alpha blockers and anticholinergics, which seems a bit counterintuitive sometimes.
Yeah, I was thinking that about alpha blockers. Aren't they used to treat BPH?
They are, yes. It's complex. It might relate to why they were prescribed in the first place, or maybe dose or specific drug. It warrants a closer look in individual cases.
Okay, what else? Smoking is a risk factor. Higher levels of DHT, that's dihydrotestosterone, the active form.
Right.
High blood sugar, so diabetes. Diet plays a role, too high fat, lots of red meat. And inflammation generally in the body.
That's a fair few things. Anything that might lower the risk.
Seems so. Eating plenty of vegetables, getting regular exercise, and maybe NSAIDs says common painkillers might be protective.
And what was that point about alcohol? Seemed a bit mixed.
Yes, that is interesting. Moderate drinking might actually decrease the risk of BPH itself, the prostate enlargement.
Okay.
But it seems linked to an increased risk of LUTS, the symptoms. So different effects possibly on the gland versus bladder function. Intriguing, isn't it? Definitely. Makes you think. Right, revision aid for these risk factors.
Let's try an acronym. A FOS HEI.
A FUS HEI.
Yeah. Age, family history, obesity, smoking, serum DHT, high glucose, eating habits, inflammation. FOS HEI.
Got it. Okay, now pathophysiology.
Yeah.
How do these things actually cause the symptoms? Let's start with BPH.
Okay, BPH. The prostate gets bigger. It sits around the urethra, so it squeezes it, like stepping on a hose pipe. That obstructs the flow.
So a weak stream, feeling like you haven't finished.
Exactly. Those voiding symptoms, primarily.
And prostate cancer. Similar mechanism?
Pretty similar, yes. A tumor growing in the prostate can also press on the urethra, block the flow, and cause LUTS.
Makes sense. What about the bladder issues, dysfunction or overactivity?
That's more about the bladder muscle, the detrusor. If it's contracting when it shouldn't, or too strongly or erratically, that leads mainly to the storage symptoms. The urgency, the frequency, needing to rush.
Okay, that clarifies the links. So given all these potential causes, when someone comes in with LUTS, it could be quite a few different things. What are the main differentials?
Absolutely. Critical point. The differential diagnosis is broad. You've got to think, could it be a simple UTI?
Right, rule that out.
Could it be primary bladder dysfunction, like detrusor overactivity? Is there a urethral stricture? Bladder stones?
Okay.
Could it be a neurogenic bladder from nerve issues? Or BPH that's definitely causing obstruction? But also maybe the bladder muscle is weak detrusor weakness causing poor emptying.
So obstruction or poor function.
Exactly. Also, chronic prostatitis inflammation, stones anywhere in the urinary tract. And crucially, malignancy prostate or bladder cancer needs consideration.
Can't miss those.
No. Then neurological diseases, MS, spinal cord injury, coda equina. And finally, are they just producing too much urine? Polyuria, maybe from diabetes or drinking too much or diuretics.
That really hammers home the need for a proper workup. Let's talk numbers. How common is this in the UK?
Very common. As we said, especially in older men, the stats suggest about 30%, so nearly a third, of men over 65 have LUTS that bother them.
30%, wow.
And storage symptoms really climb with age. Only about 3% of men in their early 40s, but up to 40% 40 by age 75 plus.
That's a huge jump. And nocturia, getting up at night.
Also very common, particularly in the oldest groups. Something like 69% of men over 85 experience it, compared to maybe 49% of women that age. Overall, estimates suggest about a third of all men will develop some urinary symptoms in their lifetime, often linked to BPH.
And do symptoms just get worse, or?
It's quite variable, actually. The studies show roughly a third improve, a third stay the same, and a third deteriorate. Good to know for managing expectations.
Okay. So clinical presentation. What are we listening for in the history, looking for on examination?
Right. Symptoms, we group them. Voiding, storage, and post-void. Voiding is the weak stream, hesitancy, straining, flow starting, and stopping intermittency.
That feeling of not emptying properly.
Yes, incomplete emptying and terminal dribbling right at the end.
Gotcha. That mnemonic again for those.
Whiston trouble. Weak, hesitancy, intermittency, straining, terminal dribbling, incomplete emptying.
Whiston trouble.
Yep.
Nice. Storage symptoms.
That's the urgency, gotta go now. Frequency going often, nocturia up at night, and urgency incontinence leaking with that urge.
And the mnemonic was?
FU and U. Frequency, urgency, nocturia, urgency incontinence, FU and U.
Brilliant. And post-void.
Mainly that post-micturition dribble, annoying leakage after you think you're done.
So someone presents with these, what's the initial workup?
Starts with a good history, obviously. Then physical exam, including the abdomen. A urine dipstick is vital check for infection. Blood.
Kidney function tests.
Maybe, yeah. Renal function blood tests if needed. And a digital rectal exam, the DRE, is key to feel the prostate. Then proper urinalysis in the lab.
Okay. And the PSA blood test, when does that come in?
We think about PSA if the symptoms suggest blockage from BPH, if the prostate feels odd on DRE, or if the patient is worried about cancer, needs careful counseling.
Any other tools? Diaries? Scores?
Yes. A frequency volume chart, a bladder diary, can be really insightful. How much, how often. And the International Prostate Symptom Score, the IPSS questionnaire, helps quantify how bad the symptoms are.
And when do you send them on to a specialist?
Referral is usually for persistent symptoms despite initial management, or if things look complicated or there's suspicion of something serious like cancer.
Right. So say they need more investigation. What else might be done?
Beyond the history, exam, urine tests, PSA, we might move to urodynamic studies.
What are they exactly?
They measure bladder pressures and flow rates during filling and emptying, really assesses function and imaging, often a transrectal ultrasound, TRUS, to get a good look at the prostate size and shape, or sometimes a kidney bladder ultrasound, maybe even an MRI, all to pin down that underlying cause.
Got it. So once you've investigated, maybe got a diagnosis, what are the management options?
It's tailored, always. Depends on cause, severity, bother factor. But we can group things. First line is often lifestyle changes. Reducing fluids before bed, avoiding irritants, caffeine, alcohol, spicy food for some. Timed, voiding going by the clock, not just waiting for the urge.
Sensible stuff. Then meds.
Medications are a mainstay. Alpha blockers like tamsulosin are often first for voiding symptoms. They relax the muscle tone.
Okay.
Then 5-alpha reductase inhibitors, 5-ARIs like finasteride, they actually shrink the prostate but take months to work fully.
And for storage symptoms, overactive bladder.
Anticholinergics are common there to calm bladder down, or marbipragron, which works differently. Sometimes you need combination therapy, maybe an alpha blocker and a 5-ARI.
What if meds and lifestyle aren't enough?
Then you consider minimally invasive procedures or surgery, especially for BPH. Things like TURP either bore, or laser options like HOLEP, 2IP, 2NA, lots of acronyms.
He's like it.
Surgery can also be an option for severe resistant storage symptoms. And for stress incontinence, which is different, an artificial sphincter might be needed.
And I saw watchful waiting.
Yes. If symptoms are mild and not bothersome, just keeping an eye on things, monitoring regularly is perfectly reasonable. Watchful waiting.
What about other non-drug approaches? Conservative stuff.
Definitely. Pelvic floor exercises, Kegels can help, bladder training to gradually hold more urine, containment products, pads, etc., distraction techniques for urgency. And if someone's in chronic retention, not emptying well, they might need intermittent self-catheterization.
Right. Specifics for nocturia. Anything else besides fluid management?
If it's true nocturnal polyuria making too much urine at night, you might consider a low-dose diuretic like furosemide taken in the afternoon, or desmopressin at bedtime to reduce urine production overnight. Needs careful consideration, though.
Now, those experimental things mentioned.
Yeah, ethanol injections, botulinum toxin, they're still under investigation, really. Not standard practice yet. The key is always tailoring the plan.
So thinking long-term, what's the typical outlook, the prognosis?
It's really variable. Some guys have persistent issues, some improve. But the good news from studies is that severe complications like acute retention, meaning urgent catheters, stones, kidney problems, aren't actually that common. Only a small percentage progress that far.
Any clues who might be more likely to progress?
Yes. Risk factors for progression seem to be having a large prostate gland, being older, say over 70, and having a low peak urine flow rate on testing.
And can treatment change that prognosis?
Absolutely. Lifestyle advice helps. And the 5-ARI drugs, prostate shrinkers, are proven to reduce the risk of acute retention and needing surgery down the line.
Okay.
And combination therapy, an alpha blocker plus a 5-ARI, seems even better at slowing progression and improving symptoms compared to either drug alone.
Good to know. And that point about PSA levels on 5-ARIs.
Crucial reminder, after about 6 months on a 5-ARI like finasteride, the PSA level typically halves. So you need to mentally double the lab result to compare it to previous levels or normal ranges. Very important interpretation point.
Definitely one to remember for exams. So prognosis depends on
the specific cause, how it's managed, whether cancer is involved, other health problems, lots of factors. Regular follow-up and sticking to the plan are key.
Right. And finally, just to round off, what are the potential complications if LUTS get severe or aren't managed?
The main ones to watch for are recurrent UTIs, acute urinary retention, suddenly being unable to pass urine at all, which is an emergency. Bladder stones can form. And in the worst case, chronic back pressure can lead to renal impairment, kidney damage.
Okay, so that wraps up our deep dives into LUTS in men. We've hit the definition, causes, risks, pathophysiology, differentials, epidemiology, presentation with those handy mnemonics.
WIST and trouble and FU and U.
Exactly. Plus investigations, the whole range of management from lifestyle to surgery, prognosis, and complications. A really solid overview, hopefully useful for revision.
Absolutely. Getting your head around LUTS is fundamental for managing these very common male health issues.
It really brings home how things like diet and exercise, the lifestyle factors, might play a bigger role than we think, and just how tricky it can be to pinpoint the exact cause with so many possibilities.
It certainly is. That careful, systematic assessment is just so important to get the diagnosis right and guide treatment effectively.
Well, if this deep dive has helped your MSRA revision, do check out pastthemsra.com. And for free resources, there's freemsra.com. Definitely worth a look. Thanks for diving deep with us today.